the range of places that people are located. So I appreciate everybody who's up at an awkward time zone to listen to this. Can everybody see my slides okay?
They look great. Thank you.
Okay, great. And then I'm happy to take questions throughout the talk. So it would probably be easiest if you just unmuted, but I'll also try to see if things pop up in the chat. That's just a little harder. Okay, so today I'm going to talk briefly about my research goals and then spend some time talking about implementation science. Not too much because I think everybody here has a pretty good idea of what that is. And then spend some more time talking about the science of teams, which I think is a little newer. And then I'll use my K23 study to illustrate how I'm drawing together these two different fields of research. So I think this is in my bio, but my research goals are to improve access and quality of care for mental health needs for children. And so we can do that by expanding mental health care to other settings where children are present, like schools, primary care, child welfare. And we can improve the quality of care in all these settings by increasing and improving our implementation of evidence-based practices. So the populations that I care the most deeply about are children who experience maltreatment, children in families in rural areas, and service providers across systems, particularly child welfare and mental health. So implementation science, we'll start here, even though I think everybody's got a decent idea of this. What we want, right, is this nice, well-constructed bridge with knowledge flowing at high speed between research and practice. But unfortunately, what we have doesn't look quite as good. So implementation science is about bridging this gap between research and practice. So Jeff Curran came up with these nice terms, right? We have our thing, the intervention or innovation that we're trying to put into practice. Implementation research is about how to help people and places do the thing. Implementation strategies are the stuff we do to help people and places do the thing. And implementation outcomes are how much and how well they do the thing. And our implementation outcomes are really necessary preconditions to get to the changes we want to see in service outcomes and clinical outcomes. Implementation science has lots and lots of theories and models and frameworks. And one thing they all have in common is that context matters, right? So we all understand that implementation unfolds dynamically over time and across levels. So when we think about our barriers and facilitators and our different levels of influences, we often think about clients or patients who are nested within providers, who work for organizations that are part of larger systems. But in healthcare and a lot of other settings, we often have care that's provided by teams, not just individuals. And this level isn't really explicitly addressed in a lot of our theories and models and frameworks. So finding this gap led me to the science of teams. So first, what do I mean by team? A team is a group of people who interact dynamically, interdependently, and adaptively towards a shared goal. And interdependence means that they have to coordinate resources and work together so that they can accomplish their goal, right? So the work of a team can't just be done by people working on their own. So a group of people who work in the same building, not necessarily a team, but a group of people who all need to use the same resources and have to coordinate their workflows with each other is a team. So you can think about a lot of different types of teams within implementation science. And so this is actually a table that I'm working on with some of the, from a paper I'm working on with some of the InStep investigators, thinking about our common types of teams we see in the literature. So we have our implementation teams or implementation support teams. And these are teams that are formed to help implement something, right? So the team is usually within an organization or sometimes the system. It's typically time limited, and the members share the responsibility for implementing a new practice. We also see existing teams, right? So we have, for example, like a surgical team. So that team exists within a hospital to get a surgery done. Everybody on that team has to work together and do their pieces. And so if you want to change something in a setting that's using a team to deliver care, you need everybody on that team to participate in making the change. We also see new care teams. So this would be when we have an innovation or an intervention that requires a team to be formed, right? So instead of people working individually to provide care, the intervention says, actually, now you all need to work together as a team and depend on each other and work together in this different way. There's also a long history of quality improvement teams, and I think we're starting to see a little bit more bridging of like the implementation science world and the quality improvement world. But these teams members share responsibility for improving care. They might be kind of a standing quality improvement team within a healthcare system, or there might be teams created for specific projects, and they're typically within an organization. And then we have all these different types of teams. We can also think about teams as multi-team systems. So this is when you have different teams that have their own individual goals, their own things they're doing, but they also have to work together towards a broader goal. So the teams themselves are interdependent with other teams. So hopefully that gives you a sense of kind of the kinds of teams we see in implementation science. There might be others as well. These are just kind of the most common. So like I said, most of our frameworks don't specifically include teams or team level determinants. And that doesn't mean we can't use them though. We don't really need any more theories or models or frameworks. So for example, we can think about teams using EPIS. So we might have teams that are within the inner context, like teams within a specific organization. We also could have teams that are more in the outer system context, like a state leadership team. Or we could have teams that are really acting as bridging factors between domains, right? So people from different organizations who form a team to work together on a project. And then, like I mentioned, the team-based models of care, we have innovations that require the creation of a team. We can also think about teams across different phases of implementation, right? So we might have teams that are formed at different times or become more or less relevant through the different phases of implementation. Okay, so that's what a team is. Now thinking about what is teamwork. I think of teamwork as a way to talk about how teams are set up, what teams and their members think, feel, and do, and how effective teams are. And so this model on the bottom here, this is kind of a pretty simplistic, but I think helpful way to think about inputs, right? So how teams are set up, the mediators, what they're thinking, feeling, and doing, and then their outcomes. And it's recursive, right? Because outcomes become inputs. Nothing is quite linear. So we think about inputs to start with. We think about aspects of team structure. So this can be interdependence, right? How interdependent are they? Some teams are more or less, interdependent than others. Things about the type of work they're doing. We can also think about how the team, who the team is comprised of. So how big is the team? How much diversity is there in individual demographic characteristics or in professional experiences? How much turnover or churn is there within a team? Then we think about team functioning. We have both processes and emergent states. So processes, I like to think about these as what teams do, right? So how do they communicate? How do they coordinate with one another? Goal specification, conflict management. And these are just a few examples. There are lots more. But thinking about really what are the things that happen within a team. And then we have our emergent states, which are things that arise out of those team interactions. So we have affective states like cohesion, trust, psychological safety. And then we also have cognitive states. So mental models about what a problem is or how to solve it, shared goals, transactive memory, which is knowing who in your team knows what. So you know who to go to for what knowledge. And then we have effectiveness. And so effectiveness is multidimensional. Part of it is performance. So the quality, efficiency, and productivity of the team's work. And that's really context specific, right? So it might be profits for one team. It could be, surgical outcomes for another team. And performance can also be measured both objectively and subjectively. It's not the only piece though. So part of what makes a team effective is not just the quality of the work they produce, but also things like viability and member outcomes. So viability is the team like sustainable? Do people want to keep working together or would they work together again? Versus this is a team that's kind of just crashed and burned. So maybe it produced great work, but it's never going to work together again. You can also think about member outcomes. outcomes. So those would be how much did members learn and grow and develop from being part of this team. And then we know all these aspects of teamwork, these things matter for outcomes that we care about in the real world, right? So we know from decades of research across lots of different settings that better teamwork is associated with greater profits, more innovation, fewer errors, and all sorts of things we care about. In healthcare settings specifically, teamwork is associated with service quality, patient safety, and clinical outcomes. Okay, so this figure is trying to bring back the science of teams into implementation science. And this figure is the conceptual model for the InStep Center. And so you can see it has some of these team inputs and team mechanisms that we just talked about. And it also incorporates things we might be more used to seeing from the implementation science world, our EVP, our implementation strategies, and those implementation outcomes and clinical or service outcomes. It also situates teams within the inner context and the outer context. Any questions so far? That's a lot. No? Okay. Feel free to interrupt at any point. Okay, so one more point I want to make about the team literature is that there's a lot of evidence that we can improve team functioning performance. So there's a huge amount of research that's been done on developing and testing team interventions. And most of this has occurred in the military and university kind of business schools or lab settings, specific industries like aviation and in healthcare. So kind of big takeaways, teamwork matters, and we can improve it, so which is really good. So thinking about implementation science and the science of teams brought me to these two questions. First, how does teamwork affect implementation of new practices? And second, can improving teamwork improve implementation? So this was the focus of my K-23 study. And so I want to give you a little bit of background on the setting for this study. So I was interested in looking at child advocacy centers, and these are designed to be a one-stop shop for children and families after allegations of severe maltreatment. So most often sexual abuse, but also other types. And they use multidisciplinary teams to both conduct coordinated investigations and connect families with needed services. So these teams are really interesting because they have people from different disciplines, different organizations, and different systems. And the membership is pretty fluid and dynamic. So who's part of the team might depend a little bit on which case. And those boundaries aren't always super clear. They're also non-hierarchical because members are answering to their own supervisors and agencies. They're not necessarily accountable to the same people as their teammates. So here's an example of what this might look like in a small rural child advocacy center. We have one person in the middle who is employed by the child advocacy center itself. And then we have members of the multidisciplinary team that are employed by different agencies, which each of the agencies represented in a gray box. And so you can see this might include medical, child welfare, maybe multiple mental health agencies, multiple law enforcement jurisdictions, a victim advocacy group, the district attorney's office. So different disciplines, different organizations, and different systems, but they're all part of the same team. So my K Awards entitled Improving Access to Mental Health Services for Rural Youth, Leveraging Multidisciplinary Teams to Enhance Implementation of a Screening and Referral Protocol in Rural Child Advocacy Centers. So it was funded just over 2 years ago. And so today I'm going to present some of the quantitative findings from EAM1 and some preliminary qualitative findings as well. Before I get started, I wanted to just thank my wonderful team of mentors, including my primary mentors, David Kolko and Greg Ahrens, as well as my consultants and collaborators, research staff, community partners, and all the participants in this study. I especially want to thank my community advisory committee. And so this is a group of frontline professionals in leadership with experience with CACs. And we've been meeting pretty regularly since 2020 to get their perspectives. And it has been really, really helpful in doing what I hope is better research. So the aims of this study were to first examine associations between teamwork and implementation outcomes in a statewide implementation effort. Aim 2 is to develop team-focused implementation strategies. And then aim 3 is to actually do a pilot trial of those. And so some context for aim 1, there was a statewide effort to implement a standardized screening and referral protocol in the CACs. And so the QR code here will take you to this paper, which describes the implementation process and barriers and facilitators that we found. So the innovation, or the thing in this case, was a mental health screening and referral protocol. And it included screening for PTSD symptoms and suicidality using evidence-based screening tools. And it also included electronic decision support for frontline providers who are typically victim advocates or other people without specialized training in mental health. So I conducted a quantitative web-based survey of team members in CACs in the state, so over 400 team members. And they completed measures of team structure, functioning, and performance. And so this paper on the bottom here is a paper where we just looked at how these different dimensions of teamwork were associated with one another in this setting. And it also has more details about all the different measures. And so briefly, we looked at aspects of team structure. So I've mentioned interdependence a few times, right? This is this reliance on one another. Task interdependence is really like, how much do I need someone else to do their thing so I can do my thing? Versus outcome interdependence is more about how the outcomes are evaluated. So am I judged on how well I did my work, or are we judged as a team on what we do as a team? So outcome interdependence is higher when what matters more for evaluation and rewards is what the team does. And then we looked at 3 different aspects of team functioning. So we looked at liking, trust, and respect within the team, learning behavior, and shared goals. And then we looked at team performance, and we had team members rate how well they thought their team was doing. So subjective measure of performance. So our implementation outcomes, we looked at individual level perceptions. So what did team members think about the protocol? Was it acceptable, appropriate, feasible? And then at the center level, we looked at implementation climate as well as reach. So our measure of reach was screening rates. How many of the kids that should have been screened in that center actually did get screened? And this link on the bottom here is to the paper that reports these results. So this is a figure just showing screening rates in the different centers over the first 2 years of implementation. And you can see there is a lot of variability. So we had some centers, that were consistently low or consistently high, but we also just had a lot that were in the middle. And some centers really changed a lot over time. So for analyses, we used linear mixed models to look at individual level outcomes. And then for our center level outcomes, we aggregated the survey measures to the team level, and then we used regression models to test associations. Our results. So when we're looking at individuals' perceptions of the protocol, we found that team affective integration, which is this liking, trust, and respect within the team, that was associated with more positive perceptions, so greater acceptability, appropriateness, and feasibility of the protocol. And then we also found that more positive perceptions of performance were associated with more positive perceptions of the protocol. At the center level, we found that task interdependence was associated with a few different outcomes, and team performance was associated with implementation climate. None of our measures of team functioning actually were associated with outcomes, which was interesting. So these 2 figures here show the implementation climate. Yes. Oh, Nicole's question. Yeah, so did I determine the team structure for the models, or did the CAC self-report determine their teams? So for this study, we asked the directors to send it out to their team members. So they decided kind of who counted as a team member and who didn't. It's been actually very interesting. For this study, we had the directors send it out. For later studies, we have gotten the information for team members and sent it out to them directly. So we've been a little bit more involved in deciding who's part of the team and who's not. And it really varies, because sometimes you have people who are part of the team in name, right? Like the police chief in this small town is part of the team, or should be, but he's never shown up to a meeting, right? So would you actually count him? Well, not really, because he wouldn't be able to tell you anything about the team, but he is actually part of the team. So it is an interesting question. I think it gets back to this like idea of like the boundaries around teams. Anything else you want to know about that, Nicole? Okay. So this figure here, this shows our findings for implementation climate. And so each of the dots in these figures is a team. And so you can see that as task interdependence, so that reliance on one another within the team increases, implementation climate was also more positive. And then the same positive association between team performance and implementation climate. And then this figure shows screening rates and task interdependence. So we found positive associations between task interdependence and screening rates immediately after the training, so in that first quarter, as well as during the whole 2-year periods. So these results suggest to me that teams with greater reliance on one another to share resources, coordinate their workflows, they might be better able to make the changes that are needed to use the protocol consistently. So summary of our quantitative findings, we found that affective team functioning and performance were associated with more positive perceptions of the innovation. Team performance was associated with better implementation climate, and task interdependence was associated with better implementation climate and higher screening rates. Any questions about the quantitative findings before I discuss a little bit of the qualitative? So we also did some qualitative interviews with team members in 6 rural CACs. So I was particularly interested in rural areas. So that's why I chose rural CACs. And we chose CACs that varied in how well they'd implemented the protocol. In each of the centers, I interviewed the director, the person who's most involved in the screening. So this is usually an advocate or a coordinator of some kind, as well as some team members who are not directly involved, so child welfare and law enforcement. So we're still analyzing these data. So these are very preliminary results, but a few things that are kind of jumping out so far. The first is that there are really varied perspectives on the involvement of team members in screening. And the second was the perceived value of team follow-up. So this is a quote from a detective talking about the screening. He said, really, other team members I don't really think need to be involved unless there's pertinent information for their specific expertise. I'm not going to give any mental health advice. I've been doing it long enough to kind of pick up on things here and there, but I am definitely not the expert. If we need to be involved in it, maybe there's a comment that was made. And so I think if there's pertinent information from team member to team member that can bring that information up and say, did you guys know, or has this been brought to anyone's attention? I think can be helped in the screener. Otherwise, you leave it to those that have that expertise. On the other hand, we have this quote also from a detective, and he said, I would train everybody on it, how it came about, what its purpose is, where the information goes, how it's used, and also kind of train on it. I think it's very important for the victim to feel empowered and feel like they have some control of the situation. I always like to give them the option of talking to me or talking to somebody else that's there. So even though these 2 people were in similar positions, they had really different perspectives on involvement, right? So one's like, nope, that's not my job, I'm not going to do it. The other said, hey, let me try, right? The second thing that jumped out was this idea that team members follow-up is really, really valuable for actually getting benefits from the screening and referral. So this quote's from a child welfare caseworker. I think in a perfect world, the workers would know more about a screener and more about what the results mean. And if they knew more about the screener, then they could utilize it better to provide the right resources and the right follow-up. And this quote is from a director. I feel like we have a really good thing going with our team where they listen to the report and help with the family, either talking about a safety plan with suicidal ideation and behavior, or just underscoring what I've said about trauma and trauma-specific treatment and trauma symptoms and things that families can do at home. I think they need to be part of the conversation so that the family has the whole support of the MDT and that team members know what's going on. Helping my team see how helpful it is for their casework as well, I really feel like we're implementing that in what I would say is the ideal way. So there does seem to be a lot of consensus that team members' involvement in the follow-up matters. So even though there's kind of these differences on opinion on who should be involved in doing the screening itself, there's a lot of agreement that like having team members know what's going on with mental health and pathways to care is really helpful. So this brings us to aim 2, which is to develop team-focused implementation strategies. And so the idea here is that maybe if we can intentionally target the team and bring in some of these team aspects of teamwork that I talked about earlier, maybe we can strengthen the implementation process. So the idea here is that we will do a systematic collaborative implementation mapping process with that community advisory committee that I mentioned earlier. We'll incorporate those findings from aim 1 about what seems to be effective and then what seems to be associated with our implementation outcomes. And we'll draw from effective team interventions like I mentioned earlier. Zooming back out a little. So out of this study, I just want to think about what could team-focused implementation strategies look like? So we've been thinking about kind of 3 different categories of team-focused strategies. So the first is strategies that create teams. So these are 2 strategies that are in the ERIC strategy list, creating new clinical teams and organizing implementation team meetings. So we already have strategies that people are using that are focused on creating teams. That feels like one group. The second kind of category of team-focused strategies might be strategies that we're already using for individuals or for organizations, but that we could focus in on teams specifically, right? So for example, audit and feedback is often used for individual providers, but we could actually use audit and feedback to target the team level by providing feedback on team level outcomes, and that would increase outcome interdependence within a team. You could also do something like develop disincentives, but not just at the organizational or individual provider level, but at the team level. So that's the second group of strategies. It's really taking strategies that we already have and just focusing them at the team level. And then the third category of strategies is a little bit different, and this is strategies that are related to improving teams. So like I mentioned earlier, we have a lot of evidence that there are effective ways to improve teamwork. So these are just a few examples. So team training, team building, these are both really broad categories of team development interventions. So team training focuses more on teaching specific knowledge and skills to support teamwork. Team building is more focused on strengthening relationships. And team debriefing is an approach to kind of getting teams to reflect on their performance and make plans for improvement. And team charters are an intervention for at the start of creating a team, setting out roles and expectations, and getting on the same page kind of early on. So there's a lot of things that we know work to improve teams, and we could take these things and apply them in an implementation context to strengthen existing teams or improve new teams that we're creating as part of an implementation strategy. So back to my study, some examples of some possible team-focused implementation strategies. that would be things like cross training. So cross training is where team members are basically learning something more about what other people on their team are doing. And the idea would be that that would increase coordination and supportive or backup behavior within the team. So teams of members' ability to help each other out. We could look at goal setting, which is a type of team building intervention. And that could increase outcome interdependence, maybe increase our implementation climate, and then improve our implementation outcomes. Or we could try self-correction, which is similar to debriefing. It's the idea of like supporting teams and learning from what they've done so far and trying to increase learning behavior in the team. So there is a ton of things we could do at the team level and leveraging these existing team development interventions. And these are just a few ideas. And the nice thing is, like, we can integrate a lot of this into things we're already doing. So it doesn't have to be a whole separate thing. For example, if we decided to cross-train team members in different things, that could be integrated into an initial training that we're already doing and how to use a protocol. A goal setting activity could be integrated into a training as well. Something like team self-correction could be delivered right alongside audit and feedback. So it's not necessarily that it would be like additional burden or additional work. It would just be adding another target and trying to activate some more mechanisms alongside our other implementation strategies. Okay, any questions? Okay. You guys are gonna have to think of some questions because I'm almost out of things to say. So Nicole,
Elizabeth, yeah, I have a question thought here.
Yeah.
This is reminding me a little bit of a potential like positive deviance approach, where could you look at teams that are implementing this screening and referral protocol well, understand kind of what they're doing to be successful, and use those as a starting point for some of these team level strategies that you would offer to other CACs.
Yeah, absolutely. And I think one of the things that's been so interesting is that what I found so far is it doesn't feel like there's one right way to do it. I think that's part of the interesting part about teams is that they can figure out a lot of things and there's a lot of variability in how they work together. And so we might not necessarily be trying to change what they do to have them do it a specific way, but really more just giving them the tools to figure out how to get to the outcome. Because just in the Utah study, we had some teams where it worked because everybody was involved. And then there were some teams where it seemed to work because everybody said, that's her job. And I fully support it, right? So it's not necessarily that there's one right way for teams to get to these outcomes. But if we can get teams to work together effectively, then they can figure out the best way to whatever outcome. Other questions or thoughts? So our last step in this this study will be to pilot test our strategies. The idea here is that we'll recruit 4 centers in rural Pennsylvania. They will all implement the same care process model, is what it's called, the screening and referral protocol. And 2 of them will get implementation as usual, so training and technical assistance, and then 2 of them will get a more intensive team-focused approach, and we'll collect data at 0, 6, and 12 months. We're also going to try to collect some effectiveness data on the protocol itself because it's fairly limited. It is using evidence-based screening tools, but obviously what we want to see is really that more kids are getting to needed treatment. So we'll try to collect some data to establish effectiveness as well. And our protocol paper was just accepted in Implementation Science Communication, so that should be out soon, hopefully. Okay, so I'm on my summary. So we haven't paid a whole lot of attention to teams and teamwork and implementation. It hasn't been ignored, but relative to the attention that we've given individual providers or organizations, teams have kind of fallen behind a little bit. but it does seem like teams and teamwork really do matter for implementation processes and outcomes. We also know that better teams provide better care. So if we can strengthen teams, we can use some of these team-focused strategies to build teams' capacity to implement evidence-based practices and improve the quality of care that they're providing. And so I think this is especially important for the populations that I care about, right? So children and families that are affected by maltreatment often have complex needs, and they're not going to be met by any one provider, any one service. And so figuring out how to support teams and working together effectively, I think, is really crucial to improving outcomes for these families. Okay, and I will just close by then thanking my funders, the National Institutes of Health, and some centers at the University of Pittsburgh for supporting this work. And thank you all for listening today. I'm happy to answer questions, and we have plenty of time for them. Hey, this is a great question. So you comment on the trust or trusting relationships under the affective state of a team. What factors are impacting trust in implementation team, and where's trust in this framework? Awesome. Yeah, so I think trust is really an interesting thing. All these affective states are so important for how teams work together. I don't know that they're necessarily something we can kind of intervene on directly, right? Like, I'm not sure we can just tell people to trust each other. I think we have to kind of go back to the behavioral processes, things that are a little bit more observable, because those emergent states really come out of the history of interactions that people have with one another. And so that reliability, right, and effective communication, I think, we might have better luck increasing trust if we try to build communication skills than if we did, trust falls. That's also my personal bias towards more like skill-focused approaches. I do think that the history of interactions is really critical. And so acknowledging that history and managing conflicts when they come up is really important. Yeah, psychological safety. Psychological safety gets like all the attention. Everybody just is very excited about it. I do think it matters. I do think it's a really hard thing to just like create. I think it really rests on a lot of building blocks that get a little bit less attention. And this too can go back to like how teams are set up when we think about the inputs, right? So if your team has constant changes and churn and turnover, you're not going to get trust because interactions are new every time, and everything is risky because you don't have that history of knowing what to expect. So I think like sometimes we need to go backwards a little to get to some of those states we want to see. Anything else you wanted to say about that comment? Other questions? Okay. Did you discover any elements of shared history that might serve as threads in the challenges the team faced? So I'm not sure if this quite gets at what you're asking, but I've been doing a lot of work with rural teams specifically. And it's been very interesting because they often do have much more shared history than teams in urban areas. And they have often a lot more, like many more personal relationships, right? So if you're looking at, child abuse professionals working together in a frontier area, they don't just know each other at work, right? Like they see each other everywhere, they know each other's families, and that can be both good and bad. So some of the good, right, is like they have generally more personal relationships. They might feel a little bit more comfortable kind of sharing when things are tough, or checking in on each other in different ways. some of the challenges. I had a team I worked with where the district attorney was running for re-election, and one of the people on the team was actively campaigning for her opponent. And as you might imagine, that created some kind of conflict within the team that maybe not quite ever going to resolve. So I think like that shared history sometimes looks different depending on the setting and the depth of interactions people have with each other.
I really appreciate your work. It's very interesting. I'm reminded, I also do work in rural counties, and I was in I don't remember the setting, it might have been a Department of Health, and we'd had a meeting to talk about something we wanted to do. And we brought refreshments, and I had a big bowl of ice. And so everybody had pretty much left the room, but I was taking the bowl of ice someplace to dump it out and coming back into the room where the people in the community didn't know I was still in the building, talking about how foolish we were for coming in with our proposal when they had gone through so much work with other teams like ours. And we were so foolish not to know of their multiple efforts to do something and the failures that they'd experienced, and they were very courteous and nice to us while we were in the room. And it just happened that I, was exposed to this pretty major challenge that wasn't being shared with us.
Well, that is a tough way to find out. CJ?
Hi, yes. Thank you so much for that wonderful presentation. I have quite a few questions, but kind of building off of that last one, you're talking about perhaps some ideological differences within the group. That's what came to mind for me. And so like one thing that I've experienced in the field is like, because I work a lot with unhoused people who use drugs, and one of their concerns with teams is whether like law enforcement is going to be a part of it, because they have some real issues with that. And so I was just wondering if something similar like this came up, in your research around teams, again, like that last comment in question, whether they can see themselves working productively, effectively with people who they might see as actually counter to the value or outcome that they desire.
Yeah, absolutely. I think the extent of shared goals within a team is highly variable. And just because you bring a group of people together and say, solve this problem, does not mean that they will have the same goals. And so I think a lot of the work that most teams go through, but these child abuse teams, like a lot of the work that they're constantly doing is figuring out what those goals are. And I think the more effective teams really do seem to have a better, much more shared goals. And a part of that comes from working together, right? Like just from getting into the field and having those interactions repeatedly. From the law enforcement side, I think some of the detectives that I have talked to, the more they work sexual abuse cases, the more they realize that there's never going to be resolution through the criminal justice system. And so the more they value the other work that team members are doing to support families. I also think there's the child advocacy centers have I think they've positioned themselves just beautifully politically, because they can be both supportive of families and tough on offenders at the same time. So I think thinking about that team structure and setup, the mission of the team is not inherently, there's no inherent bias against any one discipline. So every team has to figure out that balance for themselves. But it is kind of nicely set up from the start. And I think other fields might have a harder time finding that kind of shared ideal.
This is Susan Glockner. I really appreciated your talk. I work in teams a lot, and my one comment, kind of along those lines, is the your slide that was where you verbally said this is associated with that actually had an arrow from like effective, behavior, then produces this outcome in the trust. And really, I think the issue is it's probably bi-directional. And so the issue is if you have a team that is either you're starting a new team that already trusts each other because of past experiences, or you're on a team that's been functional in other aspects. Your trust causes people to have positive affective behavior about the team, and that's associated with good outcomes. So those three areas that were associated with good outcomes, I think it's more bi-directional. And then the question is which side is more amenable to education intervention to drive that system forward.
Absolutely. I mean, nothing in life is linear, and teams are maybe even messier than most. So even thinking about like what's a team input, what's an outcome, and it really depends on the context and the setting and the timing. You also made me think of something about, kind of the affective functioning of teams and like trust and some of those things that we think of as being like so important. I would say they might be necessary, but we need to be really careful because they're definitely not sufficient. There are lots of teams that love each other and get along great and have a good time and don't do anything useful, right? So we need to focus not just on, do people trust each other and like each other, but like, are they getting it, are they accomplishing the purpose that they're gathered together for? Because, thinking about these child abuse teams too, right? Like if you have a team that loves each other and trusts each other, you could also have a team that gossips a ton about the families they are serving and is not actually like treating them respectfully, right? So in some ways, sometimes it's nice to have a little bit of like, ooh, should I say that here? Right. And that's not always a bad thing to have in a team, a little bit of that, like, kind of keeping things in check. So as much as like we want every team to be affectively in a great place, I think we need to be careful that we don't overemphasize that because it's definitely not sufficient to get to good outcomes. Other thoughts or questions? I'd love to hear about some of the teams you guys are working with or some of the questions you have about those teams.
Well, as a family physician, you work in a team all the time because you are relying upon your receptionist to get them checked in correctly with the correct forms. And then you've got your medical assistant to ask them the right preliminary questions. And I worked in FQHCs for about half of my career, and they have a very good team. Like then in private practice, it goes to just the doctor. But what's really cool in the FQHCs, then you've got like your mid-level providers, and then you've also got social workers that are part of the team, and health educators. And if you work as a team and let people do what they're really good at, then everybody in that thing usually has a similar goal of wanting the patient to as outcome to be good, right? So the shared goal is kind of innately there. But trying to get everybody to do their part and understand their role and feel valued for their own role is what you have to try and work on. But that's just like part of everything about clinical medicine. You can't do it all by yourself, right?
Yeah, exactly. There's no more single doctor in the town handling all the medical needs, right? You need that team. And it is a constant process of kind of working together and figuring out what everybody's piece is and how you can work together most effectively.
Yeah, so if you do an intervention at one of those team members, the repercussions are felt by the whole team, whether those are positive repercussions or negative ones. So it would be, it's much better to look at the workflow as a whole and decide how each person can play a role in that intervention, as opposed to just talking to one person, and much more gets accomplished.
Yeah, absolutely. And I think when we're talking about implementing a new practice, we really need to think, how is that going to affect every single member of this team, not just the, person who's in the room with the patient.
Thank you so much for this talk. This was so helpful. I partner with First Episode Psychosis teams in Texas. And so those are very complex multidisciplinary teams. And so this was so helpful to thinking about things. I think my question is, the team focused strategies are really helpful. We're thinking a lot about team training in particular. And I think my question is, like, what trainings exist for team building or for like forming a team, because I think that's sort of a stuck point for us, is like, how do we provide training on the building a team itself? And just speaking for myself, like even as a clinical psychologist, I received very little to no training about how to build a team, and it was always kind of on the job, shadowing. These are the functioning things that help, but very little actual sort of training. And so I'm really curious if you have come across anything that you might recommend or have thoughts about that issue of team training in teams. That makes sense.
Yes, absolutely. So I would say that probably the most common, the team training I'm most familiar with is called Team Steps. And so it was developed by the Agency on Healthcare Research and Quality, and it's designed for healthcare teams. It's freely available. There's multiple different versions of it. And it focuses on skills for communication, backup behavior, and mutual support, situation monitoring. Trying to remember, there are a few more, but we tried to apply the Team Steps training to child advocacy center teams. And it ended up being a much more extensive adaptation process than we initially expected. So I will say, if you are interested in using it, it might require a decent bit of adaptation to work for the types of teams you're working with. If you're thinking about really more how to like set up a team in the first place, I would look into the like team charters literature. So I think that probably focuses more on what's the purpose of the team, right? What's everybody going to do? And that can be really helpful kind of in those earlier stages. Team Steps is a little bit more like, once you have a team, how do you get people to work together more effectively?
That's amazing. Thank you so much. I will definitely look into that.
Great. I'll also just say I accumulated quite the library of Teams articles. So if there's anything you have a question about, or you just are looking for some references to start with, feel free to send me an email and I will happily send you some of the papers that I go back to the most.
Thank you very much. That's very generous of you. I really appreciate that.
I'm just putting my email in the chat as well. Oh, and I just saw this piece about the science of team science. I meant to say this in my talk too, but so I always talk about the science of teams, because team science is really just doing science as a team, which is a different thing. Like most of you are probably doing team science. And then there's also the science of team science, which is researchers studying how researchers do science as a team. It gets a little confusing.
You've given me some wonderful ideas about how we could take advantage of some of what you're doing in a different context. So I work with urban churches that serve African-American communities, and we're working to help them build their capacity to implement evidence-based health promotion programs. So we use a lot from team science for our research, community engaged research team, our community partners and our academic partners. And we're developing the work that we're going to be doing is working as technical assistants with our church implementation teams. So I think you've given me some, I know you've given me some really interesting ideas about how we can think. We had been thinking more, very much about implementation strategies, but I hadn't made the leap that you've made to thinking about this is a team, and we are working with them as a team, but I hadn't made the leap that you're making. So I'm really just, like, wow, like it just opened up another realm of possibilities. It's very exciting to think about. We've been using the team science on ourselves, and so it's been fun to delve into how do we learn to be reflective? How do we improve our communication with each other about our roles? How do we improve communication about what we've been doing? And I really like the idea of thinking further about how we can turn that 180 degrees and think about how we can help the teams that we're working with in the churches. It's really lovely. Thank you.
Oh, good. Yeah, I would say, like, thinking about just team debriefing in particular, I think can be a really kind of easy, very brief, low-cost thing that might be something you could integrate into that technical assistance to build those team skills and reflecting on their own work. Any thoughts or questions? I know we're kind of close to wrapping up.
We might be losing people. Elizabeth, just with the shift to the new hour. Thank you for providing your email address. We've also included just a one question evaluation form here for folks to fill out. Thank you so much, Elizabeth, for joining us today.
Yeah, thank you for having me. This is wonderful.
We'll
I was
definitely
enjoying listening to these, so it's nice to get to share a little too.
Oh, we learned so much, and we'll definitely re-engage you as InStep continues to evolve.